Labral tears of the hip. The acetabular labrum has been increasingly recognized as a critical static stabilizer that contributes to greater load distribution and fluid seal of the hip joint. Loss of the labral integrity, which may occur with the repetitive sporting maneuvers, femoroacetabular impingement, or dysplasia, can result in hip or groin pain and mechanical symptoms. However, the fact that labral tears are found incidentally in a high percentage of asymptomatic patients highlights the importance of patient history and physical examination when diagnosing a labral tear as a source of hip or groin pain. Coming to the treatment, arthroscopic treatment of labral tears has gained popularity in the last decade. For labral tears secondary to femoroacetabular impingement, labral repair has consistently demonstrated better subjective patient reported outcomes than labral debridement or a resection at mid and long term follow-up. Repair versus debridement. Arthroscopic treatment of femoroacetabular impingement with labral repair in female patients resulted in superior improvement in hip functional outcomes compared with the labral debridement. In addition, a greater number of patients in a repair group subjectively rated their hip function as normal or nearly normal after surgery compared with the labral debridement group. This study was published in Arthroscopy 2013. There was one more study in JBJS 2017 compared the 10-year outcomes following arthroscopic labral debridement and labral repair for femoroacetabular improvement and found no significant difference in the rate of conversion to total hip arthroplasty or a post-operative outcome scores between the groups. There was one more study in knee surgery, sports and traumatology, April 2014. They studied in 490 patients, reported greater post-operative improvements in patient-reported outcomes for those treated with a labral repair compared to debridement. Reconstruction of the labrum. For young patients with a non-viable, irreparable labrum and no arthritis, reconstruction of the labrum should be considered. Dom et al. Reported a superior outcomes in patients treated with arthroscopic labral reconstruction compared to those treated with a labral resection. Debridement. Selective debridement may be chosen in cases of unstable flaps and labral calcifications within an otherwise stable labrum and preserved capsular labral junction. Arthroscopic treatment of CAM type of impingement of the hip. A high level activity at a young age, certain repetitive mechanical forces such as those inherent to ice hockey, congenital or acquired coxa vara, and pediatric conditions such as slipped capital femoral epiphysis and Perthes disease are associated with the development of CAM type deformity of the hip. CAM deformity is present in the majority of cases of femoroacetabular impingement and is usually located at the anterior or anterolateral head-neck junction. 6 radiographic views of the hip. Anteroposterior, false profile radiographs of the pelvis, cross table, frog lateral radiographs of the proximal part of the femur, and 45 degree 90 degree done lateral radiographs of the hip should be made for accurate characterization of the CAM morphology for pre-operative planning and can be repeated intraoperatively for the assessment of correction. Computed tomography scans, including three-dimensional reconstructions, can provide valuable information for preoperative planning. For the large cam deformities, a T capsulotomy in line with the iliofemoral ligament may be performed and then repaired side to side to avoid iatrogenic hip instability and abnormal kinematics. Arthroscopic treatment of Fincher type of impingement of the hip. Fincher impingement involves abnormal osseous contact between the prominent acetabular rim and the femoral head neck junction, causing damage to the acetabular labrum and chondrolabral junction. Pincer impingement exists in a variety of acetabular morphologies, including focal anteroposterior acetabular overcoverage, global acetabular overcoverage, acetabular retroversion, and subspine impingement. Accurate identification of the existing morphology is necessary for appropriate surgical intervention. The labral seal, the watertight junction of the labrum with the femoral head, is crucial to proper functioning of the labrum, and treatment of the damaged labrum should focus on restoring this seal. Recent research has supported the use of labral repair or refixation rather than labral debridement for the treatment of labral tears whenever possible, as evidenced by improved patient outcome scores. Patients with outbridge grade 3 to 4 changes at the time of hip arthroscopy are known to have poor outcomes following operative intervention and a high risk of failure requiring a subsequent conversion to hip arthroplasty. A growing body of information supports the role of hip arthroscopy in the treatment of symptomatic femoroacetabular impingement for relieving pain and improving function in patients without osteoarthritis. Coming to the conclusion, acetabular labrum has been increasingly recognized as a critical stabilizer of the hip joint. Labral tears are found incidentally in a lot of patients. Cause for the pain should be evaluated properly with the investigations. Proper evaluation is very important. Reconstruction of the labrum should be considered in a symptomatic patients if technically possible.